Bonjour à tous.
Good morning, everyone. Welcome to this press conference. Here, we will welcome all members of the press gallery for being here today. We'll start with questions in the room and then questions online. So if people are online and wish to ask questions, I would ask you to virtually raise your hand. Over to you, Minister. Hello, Louis. Good morning, everyone. Thank you for allowing me the opportunity to be here today with my colleagues, Drs. Tam and New. Today, together, we would like to update you on a few files related to health and public health in Canada, including agreements in principle with provinces and territories, the Canada Health Act, the Canada Dental Benefit, and the current state of COVID-19 and post-COVID condition, also known as long COVID. First, as you know, last month, Prime Minister Trudeau announced the plan entitled Working Together to Improve Healthcare for Canadians. This plan invests almost $200 billion additional dollars over 10 years. It is a plan co-developed with provinces and territories based on our shared healthcare priorities, including access to family doctors, recruitment and retention of healthcare workers, mental health, and a world-class data gathering system which will let us work together to protect health and safety. This funding includes a $2 billion top-up to the Canada Health Transfer to address immediate pressure on the healthcare system, especially pediatric care and surgical backlogs. This additional funding, combined with tax maneuvers, will lead to a drastically increased rate of federal funding for the healthcare system. On February 13th, provinces and territories agreed to the plan. Since that time, my colleague Dominique LeBlanc and I have met with provincial premiers and health ministers, as well as premiers and health ministers of territories. Following those meetings, we developed a certain number of agreements and principles. I would like to thank my provincial and territorial counterparts for their engagement and their commitment to concrete outcomes for healthcare workers, patients, and the Canadian public. Over the next few weeks, we will continue working together to put the finishing touches on action plans covering the first 3 years of the agreements in principle.
Unprecedented investments in the health of Canadians, our government will always protect the principles of Medicare enshrined in the Canada Health Act. Universal, accessible, and publicly funded healthcare is a point of pride for Canadians, and protecting it is a priority for our government. Collectively, we have made the choice to leave no one behind and deny no one necessary care, regardless of their ability to pay. As healthcare evolves, the Canada Health Act must also adapt. To this day, there have been 3 interpretation letters to that act that each have served to protect the intent of our publicly funded healthcare system. In 1985, shortly following the passage of the Canada Health Act, Minister Epp wrote to his provincial and territorial counterparts to clarify the Act's criteria, conditions, and regulatory provisions. In 1995, Minister Marleau wrote to her counterparts to provide a federal interpretation of the Act as it related to the issue of facility fees charged directly to patients receiving services at private clinics. Finally, in 2018, Minister Petitpas-Taylor wrote to her provincial and territorial colleagues to set out the diagnostic services policy and the reimbursement policy, strengthening Canada Health Act reporting. It is the responsibility of the Canadian Health Minister to apply deductions to health transfers to provinces and territories when user fees are charged to patients for medically necessary healthcare services. That is why earlier this week, the Minister of Finance issued letters informing provinces and territories of upcoming Canada Health transfer amounts and deductions, as is the normal process in advance of the CHT payments. The amounts levied a total of over $82 million in respect of patient charges levied during 2020-2021 for medically necessary services that should be accessible to patients at no cost. These deductions, which are 5 times higher than the average of previous years, include the first-ever deductions taken under the diagnostic services policy, totaling over $76 million for patient charges levied for medically necessary diagnostic imaging services. This being said, and given rapid and important changes in healthcare technology and in the scope of practice over the last few years, it's also important to make sure that the Canada Health Act continues to be interpreted to support free and universally accessible health services for medically necessary care. During the pandemic, we have indeed seen new ways of providing care. While there are many benefits to these, we have also seen an increase in reports of new patient charges to access insured health services that would otherwise be covered if provided in person by a physician. It is critical that access to medically necessary services, whether provided in person or virtually, remains based on medical need and free of charge. I have reminded earlier this week my colleagues, health ministers, of our shared responsibility to protect our universal, publicly funded health care, and that Canadians should always be able to access medically necessary services without having to pay out of pocket, no matter where they live in the country or how care is delivered. While we should strive to improve health services for Canadians, we must always ensure that the very core principles of the Canada Health Act, its public nature, universality, and accessibility, are also protected and strengthened. That is why I will be consulting with my colleagues and will be working together in the next few weeks to issue a new interpretation letter in the context of these changes. One of the ways to strengthen access to health care is through increased access to dental care to those who don't have it, starting with those who need it most, our children. Last fall, we introduced the Canada Dental Benefit, which allows eligible families to receive up to $650 tax-free dollars per year to cover dental expenses for children under 12. As of now, the benefit has helped more than 230,000 children get brighter smiles and healthier teeth. This will make an enormous difference in the oral health of Canada's children. And it's just a beginning as we work towards a more comprehensive national dental program. Before I go any further, I want to recognize an important milestone. Tomorrow is a National Day of Observance for COVID-19. It was 3 years ago, on March 11, 2020, that the World Health Organization declared a pandemic. None of us will ever forget what happened in the weeks, months, and years that followed. I urge all of us to take a moment to acknowledge the Canadians who lost their lives to COVID-19, as well as their families and loved ones. I also express on everyone's behalf our gratitude and admiration for the incredible healthcare workers who have sacrificed so much to keep us healthy and safe during this challenging time. La Journée internationale de commémoration pour la COVID-19.
Tomorrow is the National Day of Observance for COVID-19. It was 3 years ago, on March 11, 2020, that the World Health Organization declared the COVID-19 pandemic. My heart is with the Canadians who lost their lives to COVID-19, as well as their families and loved ones. I also express my gratitude and admiration for the incredible healthcare workers who have sacrificed so much to keep us healthy and safe during this challenging time. Many of us have contracted COVID-19. While some of us only felt temporary minor symptoms, we all know that even minor infections and reinfections can have long-term effects, including lasting health impacts. Post-COVID-19 condition, also known as long COVID, can have devastating physical, psychological, and socioeconomic effects. In summer, Chief Science Advisor Dr. Mona Niemer established a task force to study post-COVID-19 condition and develop guidance on how to treat it. A summary of the task force's report and a set of recommendations were published in December, and the task force published its entire report yesterday. Because science is at the heart of all of our decision-making, our government believes in investing in research, including new research on post-COVID condition, to better understand and support Canadians living with this condition. Our government has invested $20 million through the Canadian Institutes of Health Research to establish the Pan-Canadian Research Network on Post-COVID-19 Condition. This network, which is named Long COVID Web, will put more than 300 researchers in touch with Canadians with lived experience of long COVID. This will help to develop more precise diagnoses, treatments, and rehabilitation strategies. What is more, the Public Health Agency of Canada has invested $9 million in Cochrane, Canada, and the Grade Centres at McMaster University to develop clinical practice guidelines on post-COVID-19 condition. These guidelines will help healthcare professionals to identify and treat Canadians living with post-COVID-19 condition. I will now yield the floor to Drs. Tam and New. Thank you.
Bonjour à toutes et à tous.
Hello, everyone.
3 years since the WHO Director General first characterized COVID-19 as a pandemic. Reflecting back on these years, we are reminded of the challenges and sacrifices we've endured, including grieving so many lives lost due to and during COVID-19 under difficult circumstances. With a view forward, we are now taking stock of where we are today, including assessing the patterns and ongoing impact of COVID-19 on our population and health systems. The many actions we took together had an important impact in slowing spread and reducing severe outcomes of COVID-19. Modeling data has indicated that Canada's experience with COVID-19 could have been much worse. However, COVID-19 has still had an enormous impact over the past 3 years. Since January 2020, when the first cases were reported in Canada, we have experienced multiple waves of COVID-19, resulting in millions of cases, leading to over 51,000 deaths to date. The scale and duration of this unprecedented health event catalyzed a whole-of-society response that has tested the resilience and fortitude of each of us. We are now at a point in Canada where COVID-19 activity has reached a relatively steady state. In recent months, there have been no distinct variant-driven waves, such as the well-defined Alpha, Delta, and initial Omicron waves seen previously. Likewise, over the past 6 to 8 months, COVID-19 hospitalizations have been relatively stable despite the ongoing spread of Omicron subvariants. ICU admissions and deaths have also stabilized. Population immunity, estimated using regular antibody studies, is currently high and relatively stable. This level of immunity is also approaching a steady state due to the combined effect of our overall high vaccine uptake and infection-acquired immunity. However, as population immunity levels fluctuate, disease activity may also vary. While uncertainty remains about the seasonal patterns of COVID-19, the current trend suggests we may not see any major waves in the coming months as we prepare for a potential fall and winter surge. Together with international partners, we will also continue to monitor the situation closely and specifically watch for the emergence of significantly immune-evasive strains. A steady state does not mean that COVID-19 won't have serious immediate and lingering impacts. COVID-19 hospitalizations remain at relatively steady levels, but continue to have a significant impact on our healthcare systems. Likewise, there is a continued disproportionate impact on older and immunocompromised populations. We also know that COVID-19 infection can affect chronic disease rates, and that post-COVID-19 condition, or PCC, also known as long COVID, is also a significant public health challenge, as underscored by Dr. Nima's recently published PCC Task Force report. To address these challenges, it will be important to be vigilant and employ prudent, risk-based use of preventive measures as we continue to learn about the longer-term impacts and optimal vaccine strategies and treatments. The Public Health Agency of Canada's work to support clinical practice guidelines on PCC and the Canadian Institutes of Health Research's new funding to establish a pan-Canadian post-COVID-19 condition research network exemplifies some of the tangible steps being taken towards improved management and mitigation of COVID-19's longer-term impacts. Going forward, we expect ongoing circulation of SARS-CoV-2 virus, but with the availability of effective preventive measures and treatments, we will be able to manage COVID-19 in a more sustainable manner. On March the 3rd, the National Advisory Committee on Immunization, or NACI, released COVID-19 booster recommendations for the upcoming spring. NACI recommends that an additional booster dose may be offered 6 or more months after the last vaccination or infection to adults at increased risk of severe illness from COVID-19. These include people aged 80 years or older, adults 65 to 79 years of age, particularly if they do not have a known prior history of SARS-CoV-2 infection, adult residents of long-term care homes and other congregate living settings for seniors, or those with complex medical needs, and those aged 18 years and older considered to be immunocompromised. NACI recommends the use of bivalent vaccines for booster doses. Regardless of risk factors, we encourage anyone who has not yet received their primary COVID-19 series or their full 2022 booster doses to get these vaccinations. As we adjust our collective response and move towards the management of COVID-19 as a regularly occurring disease, planning for the fall must take into account the potential demands of COVID-19 and other respiratory infections on our healthcare systems. If we build on the capacity and knowledge gained in the past years in protecting ourselves, our health workforce, and each other, we will be well prepared to adapt our response to future needs. Thank you. Merci. Miigwech.
Bonjour à toutes et à tous.
Hello, everyone. Tomorrow marks 3 years since the WHO Director General first characterized COVID-19 as a pandemic. Reflecting back on these years, we are reminded of the challenges and sacrifices we've endured, including grieving so many lives lost due to and during COVID-19 under difficult circumstances. With a view forward, we are now taking stock of where we are today, including assessing the patterns and ongoing impact of COVID-19 on our population and health systems. The many interventions we took together had an important impact in slowing spread and reducing severe outcomes of COVID-19. Modeling data has indicated that Canada's experience with COVID-19 could have been much worse. However, COVID-19 has still had an enormous impact over the past 3 years. Since January 2020, when the first cases were reported in Canada, we have experienced multiple waves of COVID-19, resulting in millions of cases, leading to over 51,000 deaths to date. The scale and duration of this unprecedented health system catalyzed a whole-of-society response that has tested the resilience and fortitude of each of us. We are now at the point in Canada where COVID-19 activity has reached a relatively steady state. In recent months, there have been no distinct variant-driven waves, such as the well-defined Alpha, Delta, and initial Omicron waves seen previously. Likewise, over the past 6 to 8 months, COVID-19 hospitalizations have been relatively stable despite the ongoing spread of subvariants. ICU admissions and deaths have also stabilized. Population immunity, estimated using regular antibody studies, is currently high and relatively stable. This level of immunity is also approaching a steady state due to the combined effect of our overall high vaccine uptake and infection-acquired immunity. However, as population immunity levels fluctuate, disease activity may also vary. While uncertainty remains about the seasonal patterns for COVID-19, the current trend suggests we may not see any major waves in the coming months as we prepare for a potential fall and winter surge. Together with international partners, we will also continue to monitor the situation closely and specifically watch for the emergence of significantly immune-evasive variants. A steady state does not mean that COVID-19 won't have serious, immediate, and lingering impacts. COVID-19 hospitalizations remain at relatively steady levels, but continue to have a significant impact on our healthcare systems. Likewise, there is a continued disproportionate impact on older and immunocompromised populations. We also know that COVID-19 infection can affect chronic disease rates and that post-COVID-19 condition or long COVID is also a significant public health challenge, as underscored by Dr. Niemer's recently published PCC task force report. To address these challenges, it will be important to be vigilant and employ prudent, risk-based use of preventive measures as we continue to learn about longer-term impacts and optimal vaccine strategies and treatments. Among the tangible steps being taken towards improved management and mitigation of COVID-19's longer-term impacts, we can note the Public Health Agency of Canada's work to support clinical practice guidelines on PCC and new funding to establish a pan-Canadian post-COVID-19 condition research network through the Canadian Institutes of Health Research. Going forward, we expect ongoing circulation of the SARS-CoV-2 virus, but with the availability of effective preventive measures and treatments, we will be able to manage COVID-19 in a more sustainable manner. On March 3rd, the National Advisory Committee on Immunization, or NACI, released COVID-19 booster recommendations for the upcoming spring. NACI recommends that an additional booster dose may be offered 6 months or more after the last vaccination or infection to adults at an increased risk of severe illness from COVID-19. These include people aged 80 years or older, adults 65 to 79 years of age, particularly if they do not have a known prior history of SARS-CoV-2 infection, adult residents of long-term care homes, and other congregate living settings for seniors or those with complex medical care needs, and those aged 18 years and older considered to be immunocompromised. NACI recommends the use of bivalent vaccines for booster doses. Regardless of risk factors, we encourage anyone who has not yet received their primary COVID-19 series or their fall 2022 booster to get these vaccinations. As we adjust our collective response and move towards the management of COVID-19 as a regularly occurring disease, planning for the fall must take into account the potential demands of COVID-19 and other respiratory infections on our healthcare systems. If we build on the capacity and knowledge gained in the past years in protecting ourselves, our health workforce and each other, we will be well prepared to adapt our response to future needs. Thank you.
Merci à vous trois. On va commencer.
Thank you to the three of you. We'll start with questions here in the room, starting with David from the CBC.
CBC's health unit has done some reporting that shows for-profit surgical clinics are charging Canadians, Minister Duclos, $20,000 to $30,000 for hip replacement surgeries and knee replacement surgeries. They get around this ban by charging for medically necessary care by having the patient travel to different provinces for this operation. So 2 questions to you, Minister Duclos. Is this in keeping with the Canada Health Act, and will you be looking at cracking down on that?
Thank you. And A, we are aware of that. B, we are preoccupied with that. And C, we will address that in conversations with my colleagues, health ministers. It is clearly seen and felt that there is such a loophole in the act, which has been there for many years. It's impacting the ability of people to have access to a surgery. It is obviously imposing fees for those who do have access to a surgery. So yes, we are mindful of that, and we are going to work on that.
And to you, Mr. Duclos, again, why did the Prime Minister say spending more taxpayer money on for-profit clinics is innovative? Because we're wondering this because it's been done for years. It doesn't seem to have solved wait times, and there is some evidence that shows it increases waits overall and leads to worse outcomes. And some latest Health Canada reports show that Canadians paid millions of dollars with their credit cards despite your promises and loss. So I know you've been asked this before, but can you address the Prime Minister's comments about innovative care when...
Well, what the Prime Minister said is that the Canada Health Act has obligations, and some of these obligations are my obligations. And as Canada Health Minister, it's not by choice, it's by duty that, again, this morning, I have to issue a yearly statement on deductions that need to be applied to transfers to provinces and territories. Now, these deductions are there to protect Canadians that have to pay for medically necessary services. When it comes to the delivery of care through private delivery, and we know that the private sector delivery of healthcare in Canada has a long history. Physicians are self-employed workers. They are privately operating in Canada. They will be operating privately for years to come. The same thing for pharmacists and other healthcare workers. The way in which healthcare is provided in provinces and territories is the jurisdiction and responsibility of provincial health ministers. Whether people pay for those services is something that is part of my responsibility. And as in that context, that's why I'm announcing this morning that there will be increased deductions to transfers made to provinces and territories, and then there will be a new interpretation letter issued in a few weeks from now to deal with the fact that although we have seen great progress over the last few years, in part due to COVID-19 on virtual care and ways to amend the scope of practice to make workers work better together, to give more responsibility to important healthcare providers like nurse practitioners and physician assistants. Although this is all good news, there are risks that we see when these beneficial changes to how we use technology and workers comes with payments that people must make when they are not using the healthcare services in person by a traditional physician. And that's why this interpretation letter will be built and will be issued in a few weeks from now.
Marie Bastel, Le Devoir.
Mary Bastel, Le Devoir. Hello. I'd like to follow up on your announcement about a letter. You have signed agreements in principle, so new healthcare agreements with almost all provinces except Quebec. A few days later, you announced increased deductions to healthcare transfers. I understand where this is coming from, but the timing raises eyebrows. What is your response to people who are asking questions about this series of events? I have a legal obligation as Health Minister to enforce the Canada Health Acts. This isn't a choice I'm making. It's part of my duty. It's my yearly responsibility. I need to announce deductions. These deductions recognize the economic burden paid by Canadians and Quebecers when they access certain services that should have been provided for free. A third point. For some time, these situations have becoming increasingly frequent. We have made some good progress, especially during the COVID-19 pandemic, towards using more technology and virtual care and spreading out work among other professionals such as NPs and surgical assistants. This reduces the burden on doctors as they provide medically necessary care. But a new interpretation letter will come out soon, recognizing these advances, while at the same time noting that they ought not to create economic burdens on Canadians who are already paying for healthcare through their taxes. I want to talk to you about the timeline of deductions announced today, not ones in the past. I understand that there are certain obligations, but this comes just a few days after the announcement of agreements in principle. Are you worried that this timing will have a negative impact on the ability to sign an agreement with Quebec? 2 points. First, we always announce deductions in March, towards the end of the fiscal year. This lines up with the time transfers are provided. As a second point, we are faced with a great opportunity. Per the Canada Health Act, provinces can see the deductions refunded if there are changes in the healthcare system. So if we look at Quebec specifically, Quebec could have these deductions refunded at some point in the next 2 years if they make changes to avoid people paying for medically necessary care. Over the past 2 years, BC has already made amendments to its billing system, and the deductions affecting BC have been reduced in size. So Quebec can do the same thing over the next 2 years. It could change its own billing system so that Quebecers are not charged for medically necessary care. This will allow the deductions to be refunded. Michel Savard, La Presse Canadienne. Thank you, Minister. First, why is Quebec losing $41 million of healthcare transfers from 21-22? This is roughly half the transfers it was receiving. Are you not giving with one hand and taking with another? In some provinces, like Quebec, Health Canada has observed that certain diagnoses were linked to payments that are not allowed under the Canada Health Act. Quebec can undo this situation by putting in place solutions like those seen in British Columbia. So Quebecers have an opportunity before them. They will be able to avoid billing people for medically necessary care and diagnoses. This means they will be able to get that money back over the next 2 years. Following announcements about addressing private healthcare, you've made your NDP partners happy. Is the timing not a touch suspicious? This timing is a legal requirement. Every March, towards the end of fiscal, there is a legal obligation placed on the Government of Canada to inform provinces and territories about healthcare transfer deductions linked to Canadians paying for medically necessary care. It's not that we chose this moment, it's that it's the same date roughly every year. Because that's when provinces receive their transfers. The good news is that provinces and territories have 2 years to recoup these deductions.
Online, if you have a question, please raise your virtual hand. We will start with my colleague Mia Rapson.
Yes, good morning. I'm wondering, Minister Duclos, if you would be able to clarify what you intend to tell the provinces about private fees for these virtual visits and maybe some private surgical clinics. Do you have a sense of what you intend, if there is any time when virtual?
Well, thank you. We all have different roles in Canada when it comes to protecting the health.
Could have a fee for service. Do you intend to rule it out entirely?
Sorry, I think I noted the entire question. Thank you for that question. Now, I was going to say that we all have different roles, but the same responsibility to make sure that people receive services not on the basis of their ability to pay, but on the basis of their medical needs. Now, this is done in a context in which health ministers across provinces and territories find it both great and challenging to see the significant improvement in the technology that the health workers can use and in the way in which we can reallocate health workers across different health settings. Now, the great news is, as we've mentioned earlier, virtual care, data access, the improved work and input of nurse practitioners and physician assistants. This is all very good news for Canadians, patients and workers. However, my colleagues, health ministers, find it very difficult to individually fight against the risk that this may lead to billing for medically necessary healthcare services. Now, each of my colleagues individually it finds it more difficult to fight against the risk of private funding for medically necessary health services when they do this in isolation. That's why when we work collectively, when we recognize that these challenges are Canadian challenges, it's easier for individual provinces and territories to then act and fight against this tendency for this technology and these improvements in workplace arrangement to lead to a privatization of funding for the healthcare system. So working together, I believe we can all better address those challenges and ensure that in Canada for the years to come, despite the changes that we'll see in technology and delivery of healthcare, we will make sure that Canadians get access to free medically necessary healthcare services.
Thank you. And I guess I'm just still trying to clarify. Do you believe that there should be no fees for service charged for virtual care at all, or is there space for some charges within that sector?
There should be no fees for medically necessary healthcare services wherever people may live in this country.
Is there another question online? Please raise your hand. Je n'en vois pas. Je sais pas.
Seeing none, I don't know if anyone else in the room wants to ask a follow-up question. We could maybe do one more turn. Yes, just coming back to my colleague's question. and your partnership with the NDP and the announcement of the new interpretation letter. To what extent is this letter linked to NDP criticism? It is more to do with criticism from Canadians throughout the country. Canadians are happy about recent innovations, and that is the right term, in healthcare delivery and ways to let healthcare workers protect Canadians. But free healthcare needs to be protected. And what we are seeing is that new working environments and new technologies are changing practices, sometimes for the better, especially in remote and rural regions. We know that virtual healthcare will play a greater role in coming years to provide healthcare to people in remote and rural areas. At the same time, we do not want to penalize people because some people will need to pay for healthcare services as they will be provided virtually, and that would be a source of inequity. It would discriminate against people who do not have the resources to pay for virtual healthcare. Some people might not be able to access healthcare at all. I do understand that there is criticism from certain members of the House of Commons, but this is something that should concern all Canadians and all ministers at all levels of government. Some provinces, like British Columbia, have already taken significant steps to try to address these issues. I'd like to give the floor to someone else. I believe David has another question.
Dr. Tam, just what's your recommendation on masking at this point in the pandemic?
Well, we know that layers of protection, when done consistently together, can reduce transmission and spread. As I said in my update, we're at a relatively steady state now in terms of cases, hospitalizations, and quite low levels of ICUs and death, which puts us in a relatively good position. However, COVID is still very prevalent. And so you can look at wastewater surveillance, you can look at the other lab tests, and over 3,000, I think, people are still in the hospital each day with testing positive for COVID, which means that, I think depending on your risk factors and personal circumstances and the context of which you're gathering, for example, it's still recommended that you take precautions. And the NACI recommendation on booster doses for the highest risk. Those will continue then to help keep the spread of infection more manageable. I certainly expect as we move into the spring and summer months, and certainly in the outdoors, people should enjoy, doing much more, and may not need to mask under those circumstances. But I certainly think that people should be very well tolerating people who want to wear a mask, because you don't know the circumstances behind each individual's situation. So I don't think there's many circumstances in this country at different levels of government where masking is mandatory, but I think it's still recommended.
On va conclure avec une dernière.
We'll conclude with another colleague from Michel. I have a question about consultations and virtual healthcare. My understanding is you do not want Canadians to have to pay out of pocket for virtual care. But are you against these services altogether because they could only benefit certain portions of the population? What I should have said earlier is, or what I should have clarified, is that virtual healthcare, telehealth, has grown a great deal. Before COVID, roughly 3% of healthcare was provided virtually. Now it's roughly 18% of healthcare. It will continue to grow, and it is a good thing to improve efficiency and effectiveness. Not all healthcare can be provided virtually, but some healthcare can effectively be provided online. This reduces costs for patients in terms of time. Some people cannot travel to a clinic, so there's all sorts of advantages both for patients and healthcare workers. As I have noted, virtual healthcare has grown from representing 3 to 18% of healthcare, and it will continue to expand in the coming years. Having said that, this is new technology. And we are in uncharted territory. Private interests are playing a role, and this could lead to overbilling for medically necessary care. I use this phrasing because there is some healthcare that is not medically necessary, and payment could be accepted for in those cases. My priority is to make sure that Canadians are not paying for medically necessary healthcare virtually or in person. This concludes our press conference. Thank you. Have a good day.